Myself, Dr. Sunil Alexander. I am Secretary of Smartcity branch. I welcome you all to the 8th CD program of Smartcity branch this year. Today being Doctors' Day, first of all, I wish you all doctors a very happy Doctors' Day. Today we are having our Dr. Girish with us. He is from Renai Medicity. He will give a speech on lifestyle diseases today. I request our CD chairman, Dr. Deepak, to kindly introduce the speaker.
Thank you, sir. Myself, Dr. Deepak Thomas, CD convener, Idea Smart City. I am very happy to introduce the speaker for the day. And this is, in fact, our 8th CD program of this year. And today is a special day. It's Doctor's Day. And first of all, wishing you all a very happy Doctor's Day. And today we have got a very good guest with us also. And he's the endocrinologist from Renai Medicity. So let me introduce the speaker for the day. Dr. Girish Parthan completed MBBS from Government Medical College, Trichy. He completed his MD in Internal Medicine from the prestigious institute JIPMA, Pondicherry, following which he worked as senior resident in the Department of Endocrinology, JIPMA. He pursued DM in endocrinology from the esteemed institute PGIMER, Chandigarh. He is one among the few endocrinologists in India who has trained for performing euglycemic and hyperglycemic glucose clamp studies. He has several international publications to his name and is the co-author of the book Clinical Rounds in Endocrinology. He is one among the few endocrinologists in India who is trained for performing euglycemic and hyperglycemic clamp studies. His areas of interest include diabetes, pediatric endocrinology, and metabolic bone disorders. We are expecting a great session from you. We welcome you, sir, on behalf of Idea Smart City.
Thank you, Dr. Deepak, for the kind introduction, and also thank you, Dr. Sunil, and other members of IDF. So let's, without wasting time, let's start our topic for today, that is lifestyle disease and overview. So when Dr. Deepak had called me and said that, he needed a talk on lifestyle disorders, I mean, I was actually not sure of what exactly I should cover. Then thankfully, with his help, I hope I have a fair idea of what is expected of me, and I'll try to cover whatever possible that we can cover in 45 minutes or so. So lifestyle disease, what exactly it is. So basically, these are nothing but some disorders that are basically due to the day-to-day habits of the people, and these habits that detract people from activity and push them towards a sedentary lifestyle. And as we'll see in the subsequent slides, a lot of health disorders can be result of lifestyle disorder, inactivity and sedentary lifestyle. So predominantly some habits that push us towards an unhealthy lifestyle, and consequently a lot of health risks can happen, and these are nothing but lifestyle disorders. So what are the most common lifestyle disorders? Of course, the list is endless. The most common lifestyle disorders worldwide would be diabetes type 2, hypertension, and then we have heart diseases and stroke, diseases related to smoking, alcohol and drug abuse, and finally obesity. Of course, many of these things are interrelated, but these would be the most common lifestyle disorders. Some forms of cancers can also be considered as lifestyle disorders, although strictly they are not lifestyle disorders. So we will just have a look at the leading cause of death globally in 2019. Now these are WHO statistics, and we can see that here clearly that ischemic heart disease is the world's leading killer throughout the last 20 or 30 years. We can see that in the year 2000 as compared to year 2000, as in 2019, we can see that the deaths due to ischemic heart disease has almost gone up by 50%. Globally, around 7 million deaths are attributed to ischemic heart disease in 2000s, and now it is around 9.5 million deaths. This is followed closely by stroke, and followed by then we have some infections, lower respiratory infections, and some cancers. But if you look at overall the mortality, you can see that among the top 10, 7 of them are due to non-communicable diseases, and a majority of them are lifestyle related. For example, ischemic heart disease, stroke, COPD, diabetes, and kidney disorders. So for overall in 2019, if we look at the data worldwide, the most common cause of death is due to the lifestyle disorders. And if you look at the data from India, again we can see that heart attack and heart failure is the leading cause of mortality in India, accounting for about 16%, followed by COPD and stroke. And it is also interesting to note that in the last 10 years, the lifestyle disorders, heart attack, COPD, and stroke, have the incidence have gone up by 17, 4, and 7%, whereas those of deaths due to infections, diarrhea, tuberculosis, bronchitis have all come down. Because this just reflects the improved healthcare facilities that is available to good proportion of people in the country, but at the same time, the rising prevalence of lifestyle disorders in India. Now we can see that this is from the Government of India data, where what is happening to lifestyle disorders in India in young, that is a population less than 45. So we can see that as compared to 2017, the prevalence of diabetes, high blood pressure, and cholesterol all are going up. So diabetes was there overall 3.6% in 2017, which has gone up to 5%. Similarly, dyslipidemia, that is high cholesterol, from 5% it has gone up to almost 12%. So clearly the trend of lifestyle disorders are on the rise in India. Now these lifestyle disorders, they have a complex etiology. The most important factors which are seemingly unrelated, I mean, it is difficult to understand this, but there are some indirect factors which leads to this rapid rise in lifestyle disorders. First and foremost, rapid urbanization, and which leads to reduced physical activity and adaptation of unhealthy lifestyles, because as people live in an urban household, they have a lot of physical work to do. As we move from the village to cities, there are more job opportunities, of course, and there is limited space for exercising, and the pressure of work is also very higher. And this forces us to adopt a less healthy lifestyle. And because of these things, there are a cluster of metabolic abnormalities like elevated blood pressure, elevated blood glucose, elevated blood lipids, and elevated weight. These form the foundation for a number of disorders, including heart diseases and stroke, and even some forms of cancer. So when we try to understand this lifestyle disorders, first and foremost, there are a few important things that we should understand. Now, none of these disorders occur over a short period of time. These disorders have a long latent period, of course, over a period of months to years before the symptoms of this disorder starts up. Lifestyle disorders, people who were physically active, who were athletes in school, who had normal weight, during this period, over a period of unhealthy lifestyle, they gain weight. Again, their BMI increases, their blood pressure starts going above normal, blood glucose goes into pre-diabetes range, blood pressure goes into borderline hypertension, and even when they develop overt diabetes or hypertension, the actual manifestations of dreaded disease like cardiovascular disease or stroke again will take many years to develop. So this gives us an opportunity wherein if you intervene at the right moment, we can at least arrest the progression of many of these disorders, or even reverse if done at the right time. Now, when we look at the etiology of lifestyle disorders, or predominantly non-communicable diseases, the etiology can be modifiable. Some of them are non-modifiable, and then we have this metabolic factors. So let's look at what is the most important modifiable risk factors now, because this is actually what we can do something about. The most important risk factor for lifestyle disorders, I would say, would be physical inactivity. Hours of sitting in the table during our work. Of course, as doctors, most of us are forced to sit to our chairs during work. And even after work, we have other academic activities, again, which we are forced to sit in front of computers or books. And after all this, then we have to spend time with the family. So again, exercising or going to gym, these things take a toss. So the most important would be physical inactivity along with prolonged sitting during work hours. And along with it, we have unhealthy diets. If we just see the food you like, most of us, I mean, including me, most of us would like pizzas, burgers, cakes, chocolates. So unfortunately, all of them are calorie dense. And these calorie dense and unhealthy food are very easy to obtain and very cheap as opposed to getting a healthy meal. For example, if we go to any restaurant, you can get a puffs or samosa for just 10 rupees. Whereas if you want a salad, first of all, many of them, they do not have this option. And even if you go to a restaurant, many of the places, they are exorbitantly expensive. So unhealthy diet in the form of junk foods, including aerated drinks, carbonated drinks, which are rich in sugar, like Pepsi, Coke, or any other drinks. And then we have the other modifiable risk factors like smoking or consumption of tobacco in various forms, including chewing, and followed by alcohol. Of course, there is a consumption that drinking alcohol in moderation is good for heart. We are not going to that part, controversy. But when consumed in excess, alcohol is nothing but calories, empty calories. So when we take alcohol in excess, this builds up to calories, and this results in weight gain. Of course, the other health ill effects of alcohol, including cirrhosis, various carcinomas, including esophageal carcinomas, we are not even talking about that. We are just talking about the direct caloric effects of alcohol. And when we take alcohol, of course, it is usually associated with calorie dense food, which is are usually taken as snacks. So the major behavioral risk factors for lifestyle disorders include smoking, alcohol, unhealthy diet patterns, and physical inactivity. Of course, it is not that none of us know these factors, but yes, this is what is widely accepted as the modifiable risk factors. And we'll also see that how at least changing partly from this can have positive health outcomes. Now, physical activity. There was a paper which is published in Lancet 2016, and it was a meta-analysis of various RCTs. And in this meta-analysis, it was the authors have found that in 2015, the total number of deaths which can be attributed to physical inactivity was 1.6 million, or that is a huge 1.6 million is 16 lakh deaths was attributed to physical inactivity. And this some of them could be attributed to some cancers like colon and breast cancers, because we know breast cancer is a hormone dependent cancer, and when we have physical inactivity, this results in weight gain and increased activity of estrogen. Again, it is not that breast cancer the only causes physical activity. Similarly, colon cancer, again, it was shown that it was associated with inactivity. Of course, ischemic heart disease, stroke, and diabetes mellitus was also associated with physical inactivity, but it should be noted that 1.6 million deaths could be attributed to physical inactivity worldwide in the year 2050. And it is considered prolonged sitting is considered as the new smoking. It is shown that in women, the deleterious effects of prolonged sitting is much more higher as compared to men. It is shown that women who sit for more than 6 hours a day, they have a 94% higher chance of dying as compared to women who have less of sitting. Similarly, men had almost a 50% chance of higher chance of death as compared to persons who do not have prolonged sitting. And as again, as practicing physicians or practicing surgeons, a good number of us are forced to do this prolonged sitting. And it is estimated that a typical American spends almost 21 hours of his day in a sedentary state, either lying down or sitting. And now, along with the metabolic risk factors, this prolonged sitting can also be associated with risk of other problems, like if the posture is not right, backache, knee problems, and osteoarthritis, among others. Now, coming to the non-modifiable risk factors, now these are nothing that we can do, because as we age, we have a higher risk of diabetes, hypertension, dyslipidemia, cardiovascular diseases, and cancer. So there's nothing that we can do about it. All of us will grow old. Similarly, some ethnicities like Asians and as Indians are more prone to develop heart disease as well as type 2 diabetes. And it's also shown that Indians as a race develop diabetes as well as heart disease 10 years younger to their white counterparts. And also we know that with a similar BMI, Indians have higher degree of visceral fat. Now, visceral fat is a fat which surrounds the abdominal organs. So this fat which surrounds the abdominal organs releases a lot of substances. These are called adipokines, which can interfere with the functionality of many organ systems, including cardiovascular system. So probably because of this reason, Indians, even at lower BMI, develop heart disease and other metabolic complications as opposed to Caucasians. Similarly, gender, male, being a male puts you us at high risk for many disorders, including cardiovascular disorders. And finally, genetics. If there is a strong family history of diabetes, hypertension, dyslipidemia, or even heart disease, of course, we are at risk of developing these disorders in the future. So these things we cannot do, we cannot change these risk factors, but the risk factors what we have discussed previously, at least there is something that we can actually do about those things. And finally, the third, metabolic risk factors, because of various modifiable as well as non-modifiable risk factors, what happens is there are 3 or 4 disorders which emerge. So because of sedentary lifestyle, because of excessive consumption of calories, alcohol, because of smoking, because of less exercise, and some genetics, the blood glucose starts going up, the blood pressure goes up, cholesterol starts going up, as well as the body weight goes up. And now these are common risk factors for the development of multiple disorders, including cardiovascular diseases and stroke. Now we'll have a short look at the major lifestyle disorders. The most important will be cardiovascular disorders. The term atherosclerotic cardiovascular disorders is used to denote cardiovascular disorders as current recently. So the pathogenesis includes, we can see a normal artery here, and because of high lipids as well as insulin resistance, which is associated with diabetes, and high blood pressure, our body enters into a state of systemic inflammation, and because of this, our arteries are narrowed due to deposition of cholesterols, leading to occlusion of arteries everywhere in the body. And after a point, when the artery is completely occluded, or if the plaque ruptures, this results in an acute event. So this phenomenon, when occurs in the coronary vessels, it can result in a heart attack or acute coronary syndrome. When the plaque is building up, now that time the person usually manifests as exertional angina. While walking, the person develops chest pain, which gets relieved with rest. But when the plaque is completely occluded, that time there is a sudden cessation of blood flow to the heart, and the patient develops pain at rest. And this results in the occurrence of myocardial infarction, which is, of course, fatal if not treated immediately. Similarly, occlusion of blood vessels to the brain, blood vessels supplying the brain, results in ischemic cerebrovascular disorders, which manifest as stroke. Also, the rupture of vessels in the cerebrum can also lead to stroke, which can be hemorrhagic stroke. Usually, this manifests as paralysis of one side of body, usually hand and legs, or less commonly can be associated with deviation of face to one side, or aphasia, that is inability to speak, among other manifestations. When the blood flow to the lower limbs gets occluded, this results in the peripheral arterial disease, for which smoking is a very important risk factor. So when this happens, the patient develops pain in the calves while walking, which is again typically relieved with rest. So this is something equivalent of angina pectoris. And as the occlusion of the vessels progresses, and when the occlusion becomes near complete, the person develops gangrene. We can see in the image, and the fingers, the affected fingers fall off. The risk factors for CVD, again, non-modifiable factors are same: age, hereditary, and race. Non-modifiable risk factors are pretty much the same. The major ones would be high blood pressure, blood lipids, diabetes, reduced physical activity, smoking, as well as heavy alcohol use. There are other novel risk factors which we are not going into. Now, coming to the next major lifestyle disorders, it is diabetes. The most common form is type 2 diabetes mellitus, which is due to predominantly insulin resistance, which means there is insulin in the body, but the insulin is not working. And a good number of patients with type 2 diabetes is obese or overweight. There are rarer forms of diabetes like type 1 diabetes or other forms of diabetes, for example, steroid related diabetes, but these are much less common as compared to type 2 diabetes. Now, why is diabetes important? Is it just about some numbers? So fasting plasma glucose more than 126, HbA1c more than 6.5? Of course not. We know from elegant trials that the state of diabetes, when uncontrolled for long periods, can result in permanent damage to the vasculature in the body. There can be damage to small vessels which supplies the eye, kidneys, and nerves, which results in diabetic kidney disease, which is the leading cause of renal transplantation in United States and worldwide. And when it occurs in the eye, it results in diabetic retinopathy, which can progress to total blindness. Again, this is the leading cause of blindness after cataract worldwide. And when the small blood vessels supplying the nerves get affected, this results in peripheral neuropathy, which can lead to symptoms of numbness and paresthesia in the feet, and later on complete loss of sensations. Now, this puts the patients at risk of developing painless ulcers, which can go deep and get infected and result in loss of limbs because of amputations. Now, not just that it affects the small vessels, it also affects the larger vessels. And diabetes is a state of accelerated atherosclerosis, meaning a person with diabetes has the same risk of developing a cardiac event, for example, heart attack, as opposed to a person who the person with diabetes has the same risk of developing a future heart attack as that of a person who already had a heart attack. We all know that an individual who develops a heart attack is at much higher risk of developing a second attack. Patients with diabetic are at very high risk of developing acute coronary syndrome or simply heart attack. And at least a part of this is related to the common metabolic milieu, that is the obesity, hypertension, and insulin resistance, which are also the risk factors for heart attacks. Not only this, individuals with diabetes develop heart disease at least 10 to 15 years earlier than individuals without diabetes. And when heart disease does occur in patients with diabetes, it tends to be more severe. It is more likely that individuals with diabetes develop triple vessel disease as opposed to single vessel or double vessel disease in individuals without diabetes, and the mortality of acute coronary syndrome is also likely to be higher in individuals with diabetes. So it is simply not just about the blood glucose. We are also talking about overall quality of life as well as the risk of dying prematurely. Now, if we look at the numbers of diabetes worldwide, we have some real scary numbers. And if you see the total number of individuals with diabetes, this data is from the International Diabetes Federation Atlas of 2019, which gives the projection of individuals with diabetes worldwide. We can see the middle, the Asia Pacific region, that is the region with includes India. In 2019, there is 8.8 crores of individuals with diabetes, and the number is expected to go almost double by 20 years. And unfortunately, it is also estimated that 50% of the individuals with diabetes worldwide do not know that they have diabetes. And worldwide, you can see that in all parts of the world, the incidence of diabetes is projected to go up. For example, in Africa, it is estimated to go up by 143% in the next 25 years. And in the Middle East and North Africa, again, by almost 100%. Now, what are the risk factors for diabetes? Pretty much similar for what is heart disease. Physical inactivity, overweight, blood pressure, cholesterol, heavy alcohol, unhealthy diets, and high consumption of sugar, along with low consumption of fiber. Now, of course, there is some genetic predisposition. If both the parents have diabetes, there is a 90% chance that individual would develop diabetes. Now, coming to the third major lifestyle disorder, obesity. Obesity, WHO defines as the 21st century epidemic as diabetes, the combination of diabetes with obesity. Why? Obesity is a very strong risk factor for the development of diabetes, and the prevalence of obesity is going up, not only in developed countries, but also in developing countries, including India. In the ICMR India Diabetes study, it was shown that roughly 20 to 25% of individuals are actually obese, and similar number are overweight. And if you look at the most predominant metabolic disorder in the world, it is obesity. Of course, nobody puts up weight over a period of a few weeks. It is over a period of months and years. And it is estimated that more than 50% of world's population is overweight. And at least 1/3 of them would be actually obese. So what is this overweight and obesity? Now, this is the definition of obesity based on BMI. An ideal BMI as stratified by WHO would be 18.5 to 24.9. BMI is nothing but our weight in kilograms divided by square of height in meters. So 18 point, if your BMI is between 18.5 to 25 or 24.9, it is taken as healthy. 25 to 29.9, it is overweight, and anything more than 30 is obese. Of course, people who are more than 35, it's called obesity grade 2, and BMI more than 40 is super obese. Now, this is the WHO definition for BMI worldwide. However, for Asians, the cutoffs are slightly different. For Asians, the ideal BMI would be 18.5 to 22.9. And if a BMI is more than 23 but less than 27.5, it is overweight, and anything more than 27.5 would be obese. Now, why is this different classification for Asians? It is because it is shown that as a group, Asians develop the complications of obesity, including heart disease, diabetes, dyslipidemia, among others, at a much lower BMI. So an individual with a BMI of 28 would be at risk for heart disease as much as an individual with BMI of 31 or 32 if they are a Caucasian. So because of this, the BMI cutoffs for Indians as well as South Asians are actually lower. Of course, obesity is bad. it predisposes to diabetes, hypertension, dyslipidemia, as well as cardiac disorders. And this also leads to other disorders, including osteoarthritis of knee, varicose veins, osteoarthritis of hip, as well as cerebrovascular disorders. And in United States, it is estimated that approximately 10% of medical complications are due to obesity. Third major lifestyle disorder, hypertension. The WHO projects that by year 2025, almost 1/3 of world's adult population will be having hypertension, and that would be a total of 1.56 billion adults. And majority of this would be in developing nations. 80% of this would be in developing nations, because a good number, the majority of the population of the world is in developing nations. And in the year 2000, hypertension was predominantly a disorder of developed countries, whereas now and in the next few years, it is going to be predominantly in the developed nations, including continent of Asia and Africa. Why is hypertension important? Now, if you look at the risk factors for heart disease or for mortality, we are not talking about the actual heart disease. The risk factors which can result in deaths, for example, tobacco use, alcohol, physical inactivity, obesity, cholesterol, and blood pressure, we see that the maximum cause of deaths can be attributed to hypertension. And it is also to be noted that hypertension is called silent killer. Why? Because a good number of patients do not develop any symptoms. It's only a few lucky individuals who develop headache or giddiness along with high blood pressure, but majority of individuals do not have any symptoms. And it is the leading cause of leading risk factor for mortality worldwide. And majority of these deaths are due to cardiovascular causes. Cancer, again, like we said, it is not typically a lifestyle disorders, but at least some of the cancers can be related to lifestyle. The most important one would be cervical and lung cancer. Both of them are strongly related to smoking. And for cervical cancer, one of the risk factors is having multiple sexual partners. So again, at least partly lifestyle related. Similarly, obesity is a risk factor for breast cancer as well as colorectal cancers. I'm not going deep into cancer as a lifestyle disorder. Now, having said all the bad things about lifestyle disorders, let's see what can we actually do to prevent them. I do not want to give lifestyle advice to a group of doctors, but these are just published facts that we'll just have a brief look. So what can we do, and what is the effect of different interventions? Of course, avoiding smoking, physical activity, reducing your weight, and different types of diet. Now, if we can avoid smoking, the risk of diabetes, some forms of cancer, cardiovascular disorders, fractures, cataract, and sexual dysfunction can go down. Similarly, when we pursue physical activity, again, a lot of these problems can come down. And when we combine with a good diet, we are taking care of most of the lifestyle disorders. So limiting smoking, pursuing physical activity, along with avoiding overweight, when combined with a good diet, that is healthy type of eating healthy type of fats with plenty of fruits and vegetables, taking whole grain meals with limitations of sugar and excess calories and low sodium, can at least result in lower incidence of most lifestyle disorders, including diabetes, heart disease, some form of cancer, hypertension, and even some forms of dental disorders. Now, of course, eating diet is important and exercising is important. What actually can be the most ideal diet or the healthy diet? And what is the best exercise? Again, there is no thing called as the best diet. So there are people who have tried at least some form of weight loss would know that there are many forms of diet. There are low carbohydrate diets like keto diet, paleo diet. There are high protein diets, for example, Atkins. And then we have semi-starvation, for example, intermittent fasting. Then there are high carb, low fat diets. So there are many forms of diet, and each diet has their advantages and disadvantages. Again, there is no magic diet which suits everybody. And there are various meta-analyses which had compared the effects of different types of diets. What is shown is that in short term, most diets result in weight loss, but the long-term data is lacking for some of the diets. And whatever is the diet that we follow, it is important to maintain and stick to the diet. And again, another fundamental principle is to reduce the overall calories. Again, this may not be true for keto diets, but for most other diets, overall calories is what is matters. So if you look at the individual diets, the keto diet involves excessive intake of fats and with very low amounts of carbohydrates. In short term, it gives us excellent results. Weight loss, some patients with diabetes can stop their medicines altogether. I'm not an advocate for keto diet, but at least in short term, these diets are shown to work. The problem is that we do not have sufficient long-term data to recommend keto diet for everyone. Now we have next we have high protein diets like Atkins, where again carbohydrates are low, but proteins are high, especially meat and other proteins. This is going to be an expensive affair, and the food choice are limited, and it is often difficult to maintain. Next, among the recent trends is semi-starvation, including intermittent fasting, in which for the most popular one is 16-8 pattern, wherein a person fasts for 16 hours of a day and only eats during 8 hours. So for example, this would involve eating the dinner by 6:30. So that would be a very light dinner with a few calories. And next, the patient does not eat anything throughout the night and usually skips the breakfast. He can have clear fluids, including coffee without milk. And by lunch, the patient breaks the fast and he consumes again a low calorie meal. There are other patterns of intermittent fasting. Again, intermittent fasting has been shown to promote weight loss, reduce the risk of diabetes, heart disease, among others. So whatever is the diet, it is important to stick to it. So the fundamental principles of any diet would be this: reduce the overall number of calories, reduce the intake of saturated and trans fats, reduce the intake of sodium, simple sugars, all of us like them, reduce it. If you are a non-vegetarian, we can consume fish 1 to 2 times a week, eat plenty of fruits and vegetables. Of course, these should be fresh. Consuming the oils which are rich in MUFA and PUFA, for example, olive, canola, and peanut, sunflower, safflower oil, corn, soy. Again, there are a lot of controversies about what is the best oil, with various studies showing various results. So again, there is no one magic oil which is ideal for everybody. What is advocated is a mix of various oil is going to be better than continuing the same type of oil. So it is not that you have to use olive oil only and then we can that is the ideal way. Of course, olive oil is not suited for our style of cooking, especially the deep frying and other things. And I know there is a lot of controversies surrounding coconut oil and other things. We are not going into that. But when we use in moderation and when we rotate the oils, that is not going to harm us in the long run. And finally, reduction of alcohol consumption is also important. If we talk about the diet with maximum evidence, it is shown that those individuals who follow a Mediterranean type of diet, again, this may not be practical in our setting, but it is shown in various RCTs and various meta-analysis that individuals who follow a Mediterranean type of diet have the lowest risk of developing heart disease, some forms of cancers, and even lower risk of death as opposed to individuals who do not follow a Mediterranean diet. I would not go into the ideal nutrient composition of a diet, because again, an ideal diet could be far away from it. For example, if you are taking a low carbohydrate diet, of course, the 50 to 60% carbohydrates may not be ideal. But these are general principles which are recommended by most organizations. Around 50 to 60% of the calories from carbs, and 15% from proteins, and the rest from fat. Importantly, the intake of fiber, at least 20 to 30 grams, is important because it delays the absorption of the nutrients, especially glucose, from the gut, and this results in lesser spikes of blood glucose. And whatever is the diet we follow, at first we should try to reduce the total calories by around 500 to 1000 calories per day. And if we keep do this consistently for 7 days to 2 weeks, we expect a calorie deficit of approximately 7000 calories per week, which roughly translates to 1 kilo of weight loss. And last but not the least, of course, exercising is the cornerstone of any lifestyle disease management. And when we exercise, it produces a lot of alterations in lipolytic enzymes, which results in the elevation of HDL. Now, HDL is a good cholesterol. All the other parameters in the lipid profile are bad, but the HDL is the only one good cholesterol. And there are enough medicines to bring down the bad cholesterol, LDL or triglycerides, but very limited options are there to elevate the levels of good cholesterol, and exercise is among the strongest modality by which we can elevate the levels of good cholesterol. And ideally, an exercise schedule should involve both aspects. One is aerobic training, which would include walking, swimming, cycling, playing games like basketball, volleyball, shuttle, or anything, or as well as strengthening exercise, which are anaerobic. For example, that would include muscle training, lifting weights, or doing push-ups, or going to gym. So how does exercise improve our health? One, first, it leads to increased blood flow to the lungs as well as to the heart, and this results in vasodilatation and the formation of newer blood vessels, which leads to enhanced cardiorespiratory reserve. Similarly, it has been shown that individuals who exercise regularly, their mitochondrial biogenesis is different. So this results in lowering of adipose tissue mass, along with increased activity of myotubes in skeletal as well as cardiac muscles. Finally, exercise is also shown to be anti-inflammatory. Many bad cytokines, including IL-6, are downregulated by exercise, which translates to overall better functioning of most organ systems. Now, how much exercise we should do? Again, these must be individualized, but these are roughly what estimates of what happens when we do for an hour. For example, when we walk for an hour, roughly we burn 300 calories, and if we go for jogging, it's almost double, 675 calories. Dancing, 370 calories per hour. And for the record, what the calories that we burn by jogging for 1 hour is 675 calories. Now, these can be easily counteracted by just taking 3 simple vadas, which would have a calorie of around 200 to 250 calories. So building up calories is very easy. Or for example, taking a simple egg puff would give us around 300 to 350 calories. Whereas for us to burn that out, we have to work out for more than an hour. So starting exercise First, for most individuals who are young, we do not need any cardiovascular assessment. This is required only for patients who are above a certain age, maybe more than 50 or more than 55, especially those with heart disease or with risk factors for heart disease. But otherwise, for most individuals, it is just the need or the will to start something is important. And once we decide to do something, the whole principle is to start slowly and build up gradually. So start, the most common thing that happens as for us is that we would think that, okay, we'll start at walking or exercising in the next month or the next week or tomorrow, and this never happens. So the most important part is to just get out of the bed and get out of the bed and the room and start walking for at least 10 minutes in the initial days. And when we do this for 2 to 3 weeks, this becomes an habit which is difficult to change. And over a period of a few weeks, the time, that is 10 minutes or 15 minutes, can gradually be hiked up, and it can be increased to 30 to 45 minutes per session. And the aim, at least the minimum, should be 150 minutes per week of moderate intensity physical activity. Of course, it would be also ideal if we can mix it along with 2 sessions of resistance training per week. So what can we do? Walking, swimming, water aerobics, or any of that. And at least the American Heart Association recommends at least 5 times a week to maintain a healthy heart. And for those who are into tracking fitness, again, it is important that we do this exercise at around 65 to 90% of predicted heart rate. And so in summary, lifestyle disorders are a threat to socioeconomic aspects of nations, and appropriate actions for their management are the need of the moment. The management of lifestyle disorders, most importantly, is to control the risk factors associated with it and prevent the occurrence of lifestyle disorders. And once the person actually develops a lifestyle disorders, it is important to have a proper diagnosis and treatment for these disorders. Thank you all for the patient listening.
We are having a few questions, doctor. What are the chances that a person with gastrointestinal and what are the chances that a person with gestational diabetes develop diabetes in future?
Okay, so whatever data we have, it is that shown that the prevalence, of course, could be different in different studies, but the data shows that within 5 years, 1/4 to 50% of individuals with gestational diabetes will develop overt diabetes. Again, it is common in our part of the country that women usually put on weight after their pregnancy, and along with it, she has the added responsibility of the kid, and she has to take care of the house also. This, of course, this leaves absolutely no chance for the woman to have any form of physical exercise. And within 5 years, it is scary to note that 25 to 50% of these women develop gestational diabetes. Now, I had joined Renai Medicity almost 5 years back, and many of the mothers whom I had seen in the initial years with gestational diabetes are now coming back to me with a diagnosis of overt diabetes. Of course, I do not have numbers, but then it is sad to see that many of them who left me after the pregnancy without a diabetes, of course, GDM resolves after pregnancy. Now, many of them are coming back with a diagnosis of overt diabetes.
Doctor, I am having a question. 1 second.
Yes, doctor.
You.
Sir, actually, one question what I'm having is that actually, is there a state like pre-diabetes? Can pre-diabetes be reversed?
Excellent question, doctor. Excellent question. Okay, when we diagnose diabetes based on 3 or 4 criteria, For example, when the fasting plasma glucose is more than 126, HbA1c is more than 6.5, a random blood glucose more than 200 plus symptoms of diabetes, and a GTT 2-hour value more than 200. Now, this is diabetes. Now, of course, there is a state. Most individuals with diabetes would go through a state of pre-diabetes. That is HbA1c between 5.7 and 6.5. One. Second, fasting plasma glucose between 100 to 125. Fasting less than 100 is normal. 101 to 125. As well as a random blood glucose between 141 to 199. So the normal plasma glucose normally is fasting is less than 100, postprandial is less than 140, and HbA1c less than 5.7. Now, between the normal and the actual diabetes, fasting 101 to 125, postprandial or random 141 to 199, and HbA1c 5.7 to 6.4. This is actually pre-diabetes, and it is shown that if we intervene at this stage, this can be readily reversed. Again, the principles are simple: lose approximately 10% of the body weight, increase physical activity to at least 150 minutes. 150 is minimum. For youngsters, definitely it could be much higher. Limit the intake of sugar, eat plenty of fresh vegetables, and limit the intake of alcohol, as well as reduce smoking. Again, I sound that I sound like a preacher, but then well, definitely pre-diabetes can be reversed in a good number of individuals.
Sir, actually, it takes how much time to for the pre-diabetes to develop into a full-fledged diabetes?
Again, this would be many years because the risk factors for diabetes, obesity, hypertension, sedentary lifestyle, all of them, gradually accumulate. So it is estimated that an individual usually slowly from the normal glucose tolerance over a period of few years. I mean, we cannot give an exact time because it varies from individual to individuals, but it's usually over a period of 3 to 10 years. And if you are sedentary and if you're putting on more weight, and if you're not doing anything about it, definitely this can be faster. In an Indian study, in a study from Chennai, it was shown that the median duration or individuals with pre-diabetes progress over a period of 6 to 7 years to overt diabetes.
Thank you, sir.
In a pre-diabetic condition, should we take medication or just control the diet and exercise, etc.?
Good question again. So again, this is usually individualized. For younger individuals who are highly motivated, definitely a good number of these individuals can be managed without medications. But if we have strong family history of diabetes, if we are more than 50 years, we can consider metformin for prevention of pre-diabetes. But in the diabetes prevention trial, which enrolled a huge number of patients, it was seen that the most effective way of preventing the progression of pre-diabetes to diabetes is actually lifestyle measures. The lifestyle measures could reduce almost the progression in 31%, whereas the drugs was actually less effective. So unless we follow a healthy lifestyle, just by taking a tablet, this is not going to help, because the whole problem, this is called a common soil hypothesis, because the risk factor for diabetes is still there. Obesity, sedentary lifestyle, not having enough physical activity, excess calories. So unless we control them, taking a simple drug may not be effective in most patients. So yes, a physical activity with a healthy lifestyle is really important. And also for doctors, it is important. Of course, we should find out for exercising in the early morning hours or night hours, which many of us are unable to. But then it is important for us because we spend we have 24 hours a day, and at least for 30 to 35 minutes, we should spend this time for ourselves. This is some quality time for me. Forget reading a book or watching a movie. At least a half an hour, if we can dedicate to ourselves, that would be a good investment for our future.
Doctor, I'm having another question. Suppose a lady is having PCOD, metformin is usually given for the treatment of PCOD. But these ladies usually, after a period of time, they develop diabetes. That is what is seen. Is it proved or it is a myth?
Again, if you look at the risk factors for diabetes, one of the important risk factor is PCOD. Again, PCOD stems from basically obesity and insulin resistance. So PCOD is nothing but a manifestation, in most individuals, it is a manifestation of insulin resistance. Now, if you look at the pathophysiology of type 2 diabetes, again, it is insulin resistance. So it is simply nothing but the natural progression of the disease. Obesity, along with insulin resistance, having PCOD and progressing to type 2 diabetes. So in these individuals with PCOD, just giving metformin is not going to be enough. Those individuals are similar to those having pre-diabetes, and if appropriately managed, these things are very easy to say that, to reduce your weight, cut down your food, increase physical activity, but actually this never happens. And most of us as practitioners also do not have time to sit and explain these things to our patient. We just tell them, okay, you need to cut down your weight, you need to do exercise, and patient also hears in this year, it goes of the other. So just giving metformin is not going to prevent the progression of PCOD to diabetes.
And if a patient is having diabetic neuropathy, what all care should be taken? Can it be reversed by blood circulation or something like that? And what can be done to increase the blood flow in the limbs?
Again, diabetic neuropathy is actually not to, basically it is not to the reduction of blood flow. Here what happens is that the nerves which supply the lower limb, they have smaller, very small blood vessels which supply these nerves, and these small blood vessels are gradually occluded. So there is no way to directly open these blood vessels. But the most important aspect to treat diabetic neuropathy would be to attain a good glycemic control. So if the blood glucose control is good, a good number of patients can expect relief of symptoms of neuropathy. And especially if it is in the early stage of neuropathy, a good number can have a resolution of neuropathy as well, at least the symptoms. But those who have an advanced state of diabetic neuropathy, wherein absolutely they cannot feel any sensations, there it is actually something like a damage control. Whatever we do, the person's sensations is not going to come down, come back. Here what we do is to prevent the damages due to neuropathy. That is, the basic risk of neuropathy is that once the person becomes totally person loses sensations, he can develop minor wounds which goes unnoticed, and these are painless wounds, especially on the soles of the feet, and this usually gradually enlarges in size, and we usually notice them at a very late stage. So here the foot care and examining foot every day, prescribing customized footwear to the patient, this would prevent complications of neuropathy. And if there are any ulcers found, appropriate management at an early stage would lead to loss of limbs in patients with late stage neuropathy.
Suppose a patient comes to us and to a dentist, and we feel that he is diabetic. Which is the best test to do, whether it is fasting or postprandial?
Again, the best test, there is no single best test, but if you want to say the best test, it would be an oral glucose tolerance test, but then it is not practical. So if you're looking at the practicality, an HbA1c would be an ideal when done from a good lab, because it covers the blood glucose for the last 3 months. It gives us an estimate of blood glucose for the 3 months. So for convenience, HbA1c, but otherwise a postprandial as well as a fasting. I mean, ideally both should be done. Why? Because the HbA1c would not show if the person has become diabetic recently. For example, somebody is taking steroids for a week or 10 days, his blood glucose would have gone up, then that would not be shown in his HbA1c. So here at least a random blood glucose would show us, that his blood glucose is normal. It's not normal. So in a person without these, yes, an HbA1c would be the most easiest one, because you do not have to. It can be done at any point of time, even in the evening we can do it. Or otherwise, if we can do a fasting as well as a postprandial at some other day, that would be a cost effective approach, because HbA1c is going to cost a lot, around 400 or 500 rupees, whereas a fasting and postprandial would cost less than, say, 50 or 60 rupees in most laboratories.
Sir, one thing just I want to ask is that the steroid intake for how many months would lead to the development of type 2 diabetes?
Again, a steroid does not lead to type 2 diabetes. It is actually steroid-induced diabetes. Again, this does not develop in all. For example, if a person the steroids usually induce diabetes in people usually with borderline diabetes, for example, pre-diabetes. In these individuals, suddenly the blood glucose goes up, whereas people with very low HbA1c, for example, 5.2, 5.3, usually a small dose of steroids is not troublesome. But of course, when we give a large dose of steroids, even for 48 hours, they can develop diabetes. For example, dexamethasone, when given in the dose of 8 milligram twice daily and all, definitely within 48 hours the patient can develop diabetes. But then usually in most individuals without diabetes, this is reversible. When we stop this, the diabetes also resolves. However, when we use anything more than say 20 milligram of hydrocortisone or prednisolone 7.5 milligram for more than a month or so, the risk of diabetes as well as other complications goes up. So it is one acute heavy dosage when given for a short while, yes, it can cause diabetes, or a small dose, anything more than 7.5 to 10 milligram of prednisolone when given for prolonged periods. Again, this can result in permanent diabetes.
Sir, that may be one of the possible reasons. Like we have read in some recent articles that the people who are found to be COVID affected, they were given high steroids, and there is high chance of developing diabetes.
Yes, a good number of patients with COVID, especially those with category C, among the few drugs which are found to be beneficial for COVID is steroids. So they are treated with high dose of steroids. Basically, they are given for their anti-inflammatory effect. If you see the effects of COVID, it is not the COVID virus that is actually killing us. It is our body's response which is killing us. So we give steroids as immunosuppressant, immunomodulators, and a good number of patients develop with diabetes. But usually the patients with the HbA1c of less than 5.7, the dose of steroids, the dose of anti-diabetic medications, usually insulin, can be stopped within a short period of time. So most patients with steroid-induced diabetes, if they do not have diabetes in the past, we can stop them of all medications, because we use this typically for 1 or 2 weeks, and this is not going to be permanently diabetogenic.
Doctor, we are having another question. Will use of painkillers for a long time cause diabetes?
Dr. Saumian, no, definitely it does not. But definitely it can kill our kidneys. So anti-inflammatory drugs like brufen, ibuprofen, diclofenac, indomethacin, among others. So when used for long periods, can cause direct damage to the kidneys. It can lead to something called analgesic-induced nephropathy, which can be irreversible. One. Second, there is also some data to show that some of the anti-inflammatory medicines like COX-2 inhibitors, which were very popular a few years back, can result in increased risk of heart disorders. So diabetes, no, at least you can be safe. Kidneys, no, definitely they can cause trouble.
Thank you, doctor. It was a very wonderful session, especially in the present COVID situation. We will be facing more troubles because of less mobility and all. And thank you, doctor, for the very wonderful session. It was very informative. Thank you all. We are having very good responses also from the participants. Thank you, doctor.
Thank you all. Thank you all for patiently listening.
Thank you,
Good night,
doctor.
everybody.
Good night.
Thank you, doctor. Happy Doctor's Day. Bye. Good night.
Happy Doctors to you all. Thank you. Stay safe.